Hello, everyone. Thank you so much for joining us today for our webinar entitled, How Can Your Organization Meet CMS Stage 1 Meaningful Use Objectives in 2011 while establishing a foundation to meet future objectives? We're happy to have you with us, and today's presenter is Mr. Hamid Nouri, the Chief Executive Officer and co-founder of HIT Services Partners. Mr. Nouri has over 30 years of experience in IT and healthcare industry. Prior to HITSP, he led a global IT management consultancy and for 7 years served as the group vice president for the IT management consulting and client services at Gartner. Mr. Nouri possesses a deep understanding of trends, drivers, and challenges facing many segments of the healthcare community, with a particular focus on health information technology and health information exchange. He has extensive experience and deep understanding of how to assist clients track and respond the evolution of the federal initiatives in support of the adoption of HIT and promotion of statewide HIE. Mr. Nouri has conducted a number of HIT and HIE readiness and strategy engagements over the past 3 years for large state and local health and human services agencies, helping his clients develop roadmaps for practical deployment of strategic and proven HIT solutions. That's what we're going to be discussing today, and now I'm going to turn over the reins, if you will, to Mr. Nouri, Mr. Hamid Nouri. Feel free to ask any questions by typing them in the sidebar in the panel. We will have a question and answer session at the end. We'll also be providing a recorded version of this webinar after. We'll send you an email, and you'll be able to share it with your colleagues. So I'm going to turn it over to Hamid. Please take over.
Great. Good morning, ladies and gentlemen. Good morning, Stephanie. Thank you very much for the introduction. Thank you for being with us this morning. We have a timely topic at hand, and we're going to spend the next 50 minutes together discussing a subject probably that hopefully is of interest to this audience and many more across the country. And that is the emerging developments around the adoption and use of electronic health information technologies and EHR systems around the country with both eligible providers, physicians, as well as hospitals and critical access hospitals. Let me walk us through specific discussion topics that we'll go through together. What you'll see on the screen is a quick view of the agenda that we'll talk about today. We'll start with the session takeaways, which we hope to be able to leave with you at the end of this session. We'll talk about some of the challenges that face many of the state and regional HIE planners around the country and what we've been hearing from clients over the last year or so. We'll specifically talk about the CMS incentive programs for providers and hospitals. We'll get into the concepts of meaningful use and why is that relevant and important for the next few years. We'll specifically talk about Project Direct and talk about the implications of what that project is all about and how it can help. We'll get into specific details around the benefits that you can expect from adoption and implementation of the specifications. We'll give some examples of technical implementation strategies. We'll get into a little bit about the ONC effort around the Project Direct, as well as the pilots that are going on around the country and their status. We'll then get into the national context for what's going on with health information exchange around the country and deal with hidden challenges that we see with both Project Direct and HIE deployments. And end with how some of these concepts can be leveraged into a full-fledged health information exchange for your state or region. As Stephanie highlighted, we'll have an opportunity to have about 10 minutes of questions and answers. So please feel free to type in your questions. So, Stephanie will compile them, and we'll try to address as many of them as we can in the last 10 minutes of our time together. So let's go ahead and get started. So starting with the session takeaways, our hope is to leave you with an understanding of some of the hidden challenges in trying to meet Stage 1 meaningful use. We'll get into some of the status updates around the HIE developments and the direct project pilots around the country. We'll give some examples of the direct project deployments. We'll talk about technical implementation efforts around the country. We'll talk about specifically how the direct project can enable the protection of health information, personal PHIs, and the secure exchange of clinical data, and how you could actually leverage direct project to provide a meaningful and viable platform for you to meet your MU objectives for this year. So starting with challenges, these are some of the top items that we hear from folks who are involved with trying to address this challenge around setting up the infrastructure needed for the healthcare and some of the reform opportunities that are upon us. Number one is how can we deploy a rapid and low-risk solution to meet Stage 1 meaningful use requirements? This seems to be the top question as the Center for Medicaid and Medicare Services incentive programs have started this year as of 2011. And with that, the states have a responsibility and obligation to the Office of National Coordinator to ensure that the capability within the state exists in every region to enable any eligible provider or hospital who is interested in applying for the incentives to be able to demonstrate and attest to their ability to meet the specific objectives that we'll talk about today. How can we specifically provide at least one method of clinical data exchange for all urban as well as our rural eligible providers? That's going to be critical for all state planners this year. How can the initial investments that you make this year be leveraged into a long-term full infrastructure around health information exchange? And last two, how can we rapidly develop and deploy the support infrastructure that we need to serve the tens and maybe thousands of doctors within the region or within the community? And finally, how will the candidate exchange infrastructure technologies that we have will fit into the long-term plan for supportive technology for the state and the region? So these are the topics that we hear quite a bit about, and we'll try to explore some of those in our discussions today. So starting with our CMS incentive discussion, there are three major incentive programs that are talked about and are in essence being applied and used across many states today. The dominant one that we are trying to address in this discussion is the Electronic Health Record Incentive Program. So specifically the ARRA Act and specifically the HITECH within that has established programs that provides up to $64,000 through the Medicaid program or $44,000 through the Medicare program as incentive for eligible providers to be able to invest in electronic health record technologies and connect to other colleagues, physicians, practitioners, and be able to exchange clinical data. That is one of the top incentive programs that is of interest this year. There's also been two other programs that have been around for a little bit, and those two are also being explored by many providers. And the first one is the Electronic Prescription Incentive Program. That's been around since 2009, and that in essence also provides additional incentives for the doctors to receive benefits from CMS as they implement that capability, and also the Physician Quality Reporting System that was introduced as a part of the 2006 Tax Relief Act. On page 8 in front of you, what you see is the specific timelines associated with the EHR incentive program. This is the most visible and the most recent incentive program from CMS, and specifically it started in discussions in fall of 2010 as ONC, the Office of National Coordinator, was able to start to certify specific EHR, electronic health record systems, and the registration process for the incentive program basically started in January of this year. And actually the first checks have started to be issued as of last month. So the program is well on its way, and there are specific deadlines that have to be met for both hospitals and eligible providers to sign up for the program. And the program is expected to last up until 2021, and the eligible providers can actually apply as late as 2016 to be able to qualify for those incentives. On page 9 and 10, we'll briefly speak to the Medicaid and the Medicare incentives. Medicaid program, as you are familiar, is for the needy or folks who do not have insurance coverage within specific states or regions. And the Medicaid program is able to provide up to almost $64,000 in incentives. And the criteria is that the eligible providers need to have at least 30% of their patient population actually be covered through the Medicaid or Medicare programs, and they have to demonstrate that over the 90-day period they're able to achieve the meaningful use objectives. As I said before, the programs can actually be leveraged as late as 2016. So we are seeing as early as this year eligible providers applying and receiving incentives, and the payments are being made out over the next 6 years, all adding up to about $64,000. On page 10, it's a quick summary of the Medicare incentive program. Again, available up to $44,000 and paid out over a period of 5 years. So let's get into the crux of our discussion about what is meaningful use and why HIEs are relevant to this discussion. So meaningful use is a subject that I think you've heard about and very familiar with. So specifically, it has to do with use of certified electronic health record technologies to improve quality, safety, efficiency, and reduce health disparities, being able to engage patients and families proactively in their healthcare process, and improve care coordination and overall population and public health. All of this while we maintain privacy and security. So this is the purpose of meaningful use, and what we'll talk about today is the specific objectives that have been laid out that has to be met in order for both physicians or eligible providers and hospitals to be able to qualify for these incentives. Also, I should mention that hospital incentives can start in the $2 million range and could go higher from there depending on the specific hospital situation and the patients served. Specific requirements is what's highlighted in the second part of the slide. Eligible providers must complete what's called core objectives, and there's 15 of those. And there's also a menu set, meaning the items that you can choose from. We'll talk specifically about those in a moment here. You have about 15 core objectives. You have to choose 5 out of the 10 menu set. And there's also a need to report and establish 6 clinical quality measures, both 3 core and 3 out of a menu of about 38. On page 13, you will see a listing of those specific core objectives. So for a physician or eligible provider to be able to qualify, they have to be able to demonstrate or attest in 2011 to their capabilities in meeting the objectives that are highlighted here. Each one of these objectives have a specific formulas and criteria that has to be met. And you will see in here specifically number 14, the ability or capability to exchange key clinical information among providers of care. That, in essence, has significant implications for the HIE infrastructure within a state or region. And that basically becomes the topic of our discussion around how to enable that information exchange. On the next slide, page 14, you will see the actual menu set. These are the 10 items that you have to choose from. 5 of these have to be met. And there should be at least 1 public health objective in that menu of 5 that you're selecting from. Again, depending on what you choose here, there could be significant implications for the health information exchange infrastructure that needs to be available within the state. On page 15, we get into the specifics about the CQMs, or clinical quality measures. There has to be at least 6 of them, 3 of the following: hypertension, preventative care and screening measures, and adult weight screening and follow-up. Along the lines of the 6, you have about 3 additional ones that have to be selected from a menu of about 38. These have to be reported as early as 2011. And specifically, what needs to be reported are the aggregate, what's called numerators and denominators, which are the formulas used to determine whether you have met those objectives within the patient or client base that the eligible provider is addressing. Moving on to page 16, so what are the implications of all of this for the HIE and his capability? So let me define the terminology. HIE, again, is Health Information Exchange, which is a terminology that's been now standardized in the U.S. at least by the Health and Human Services Agency and the Office of National Coordinator, to be referring to specifically the ability to exchange clinical data and other relevant clinical information to all stakeholders who are involved, including eligible providers, hospitals, critical access hospitals, laboratories, radiologists, pharmacies, and so on and so forth. The specific requirements for Stage 1 in 2011 is the three key elements that you see here, and that is, first, the sharing of patient care summaries across unaffiliated organizations. That has, again, significant implications for having the HIE infrastructure in place over the next 6 months or so. The receipt of structured lab results, the ability to order the lab and being able to receive the data so it could be loaded into your EMR, EHR systems, and electronic prescribing capability. Those three have been highlighted as the top priorities by the Office of National Coordinator for the state in 2011. So how do we deal with this request and this requirement given the current state of the industry, technology availability, and the vendor offerings? So we'll get into that in a little bit here, starting with the concept of what's called Project Direct. So Project Direct is a project that came about almost a year to a year and a half ago as a result of discussions that were started as a part of the Office of National Coordinator ONC planning process, in which, as they were developing the required standards for exchange of clinical data, they started to establish some very stringent requirements on everything from the semantics and vocabularies and the ability to be able to pull data about any patient. As you can well imagine, that has significant implications of how to reconcile the differences between how patients are defined across many different automated systems, and of course the more challenging part, the fact that many physicians and general practitioners do not have any electronic or computerized clinical management systems. So with that in mind, a blog was started about a year and a half ago that suggested to leverage industry best practices around how Internet and Internet-related standards have taken hold and became dominant in the industry, and to use similar concepts and a more simplified approach to communications and the standard setting to be able to achieve broader adoption. And that basically was the genesis of the Project Direct that was created under the auspices of the Office of National Coordinator. So the idea is to have a set of standards, services, and policy framework that enables all participants to be able to achieve simple, directed, routed, and scalable transport over the Internet in a secure fashion to be able to exchange clinical data. All of this to be able to achieve meaningful use of EHR technologies. So that was the primary objective that was set forth by Project Direct, and that project is now about 15 months old and has achieved quite substantial, progress since then. Page 19 speaks to what is the problem that we're trying to address with Direct Project, and how is that different than the compared to the national standards that we've already established for HIEs. So there's three key elements here that was the focus of Project Direct. Number one, the problem that we have is communication of health information amongst providers and patients pretty much are very manual and rely on mail and fax. The issue there that it's very slow, inconvenient, expensive, and not very secure. And many times the information and history is lost in paper and charts that we have. Another issue, as I mentioned earlier, is the security aspect. As we basically fax information to each other, a lot of times the personal health or PHI information is actually going to be exposed to unintended audiences. Here we need to look at possible ways to improve security compared to current methods. And finally, in order to meet Stage 1 meaningful use requirements, physicians need to have an easy way to transport and share clinical data. And that is basically the three key issues that the Project Direct tries to address. So starting with the first concept, how do we start to use the Project Direct to facilitate our meaningful use? The Direct Project was established to make it very easy to start to share data. And specifically, you can see examples of some of the content that should be shared. such as clinical information, referrals, meaning summary of care records, test results from labs, and also being able to engage the patients by allowing them access to their personal health information, discharge instructions, clinical summaries, reminders, and finally also enabled population health goals that we have within the state by enabling reporting to our immunization registries, being able to achieve syndromic surveillance for the state, and also reportable labs to the state. Those are the typical meaningful use scenarios that you see in many states. And the concept is to provide a very easy to use direct address, which is very similar to your email address, but it is completely secure, both in terms of traveling across the wire as well as the content that is enclosed within that message. This information would be able to be shared across providers who are part of the same health information organization or regional HIE, as well as any what's called HISPs or health information service providers. And that enables, in essence, what we call the concept of a push sharing of the data. So a specific context is what's covered on page 21. The DIRECT project will actually conform to all federal and state laws and ensures the security and privacy of protected health information. So that's one of the key requirements that the DIRECT project had from a design perspective. As required by law, the sender has to have the consent of the patient. So obviously the goals and the laws and regulations within each state vary. And it's important that we make the requirement and the obligation to be on the sender to ensure that the patient consent using whatever the policies and the regulations are within the state are met before any data is shared. The sender of the direct message has determined that it's clinically and legally appropriate to share this data with the sender. The sender also has to make sure that the receiver's address is correct. The sender has to communicate to the receiver why they're actually sending that information. And the sender and receiver don't need to have a common or a pre-negotiated identifier of the patient, meaning that they could have systems or no systems that define the patient differently, but they're able to use technologies that allows them to send information about that patient to their colleague who has a role to play in fulfilling the clinical needs of that particular patient. The scope specifically is about transport and interoperability. However, DIRECT project by itself is not going to achieve interoperability in the pure sense of the word. Interoperability has a very specific meaning and connotation and has three prerequisite components. Those are transport, meaning how they will send and receive the messages. The content, meaning how the structure and format of the content is presented. And the vocabulary, what terms are used within the content. The DIRECT project is focused really on the first, which is the transport. And it is much more easier and simpler to implement for many states compared to the broader HIE standards that have been set. The use cases that will be enabled by the Project DIRECT are highlighted on page 23. As you'll see there, the scenarios that we have are a primary care provider referring a patient to a specialist, including the sharing of summary care record, primary care provider referring patients to the hospital, specialist sending summary care information back to the referring provider, hospital sending discharge information to the provider, lab sending lab results to the ordering provider, transaction sender receiving the delivery receipt that the information has been successfully received in a secure fashion, provider sending patient health information to the patient or hospital doing the same, provider sending clinical summary to an office visit, hospital sending a clinical summary at discharge to the patient, and provider sending reminders for preventative or follow-up care, and finally, primary care provider sending patient immunization data to public health. This is probably a good sampling of the typical exchange that can be enabled and will be the focus of many states for the initial deployment in 2011-2012. So how does a state or a region who's looking at technologies can leverage the concept of Project DIRECT and the related standards with Project DIRECT? So this concept is actually fairly simple, but maybe technically challenging to implement depending on the capabilities that exist with the state designated entity or the RIO responsible for this. But in essence, what is needed is the concept of having a health information service provider, HISP, available to be able to issue an address, which in essence assigns a secure digital certificate to a particular participant, and for them to be able to use that digital certificate to encrypt and secure all communications across providers who are a part of that network. So specifically, we're talking about the HISP packaging the message content using a specific standard called MIME, Multipurpose Internet Mail Extensions. There's also options to support IHE standards such as XDM, securing the confidentiality and integrity by ensuring that we are using secure MIME for encryptions and signatures, ensuring the authenticity of the sender and receiver using X.509 certificates, and routing the message through SMTP protocol and other protocol as appropriate. So in most cases, we need an eligible provider to be able to have a HISP available. They need to be able to sign up to that HISP, be able to receive a direct address from that HISP, be able to receive the digital certificate that has been authorized by the authorities within that state, and for them to be able to share information with other participants within the same HISP, or be able to share information across HISPs that operate within the state. So that is, in essence, the capability that we're looking to implement to have Project Direct available within the state. What do we need on the provider side? Actually, fairly simple. It is really what we're very accustomed to these days, and that is having an email client software. Example would be an Outlook, webmail, and many others that are available out there. They need to have, ideally, a high-speed connection to the internet, but even dial-up in certain circumstances can work. So this may be very useful for some of the rural areas within the states that we have around the country. Obviously, they would need to sign up with a HISP within the state and be assigned a direct project address and make sure that they comply with the HIPAA security requirements. So that, in essence, is what we're looking for. And once a direct address has been assigned, that practitioner should be able to look up specific colleagues and individual providers or hospitals within the HISP environment, if there's an appropriate master provider directory, and be able to send secure information to that particular physician at the other end. On page 27, we get into a little bit of the specific technical implementation scenarios. So the direct project is really about packaging the message content, securing it, and transporting it. That's really the focus. And as you can see with the graphic on the right, which talks about the capabilities that are needed from a HISP, the facilitator, if you will, is that we're looking for enabling the secure MIME connectivity from the provider across the HISP onto the recipient. We also want to be able to have the ability to use common contemporary standards such as web services and a SOAP client, and specifically enable the IHE XDM push scenarios in this context. So what we're looking at specifically is the address has to be assigned just like an email address. The message has to be packaged using secure MIME, or MIME specifically, and then from a confidentiality and integrity point of view, we have to use the secure MIME capabilities, and every message has to be signed using digital certificates. Non-repudiation speaks to the fact that there's technologies out there that enable us to guarantee that we know who sent the message is who they say they are, and who received it, in fact, received it, and they are who they say they are. This concept is implemented through a concept of what's called PKI, the public key infrastructure, and the X.509 digital certificate is the technology approach behind that ensures the integrity and security of the content as it travels from the initiator, from the sender's perspective, over the network, across the HISP environment, onto the recipient at the other end. And of course, what we're using for routing is simple SMTP to achieve that. So that's the quick overview of Direct Project. What it's all about is really simply using available standards, common technologies, things that have worked for many, many years, and apply it to the problem at hand, where we need to have very secure infrastructure that allows us to communicate highly sensitive data. And of course, this infrastructure has to evolve over time to have a lot more capabilities that we'll talk about in the next few minutes. So let's talk about the Project Direct pilots. One of the things that happened about a year ago is, as the Direct project specifications were started to be discussed, is the fact that the ONC, Office of National Coordinator, was intending to provide a lot of guidance to the folks who want to implement this, and they were looking for pilots where specific organizations were willing to come to the table, discuss the standards, and then take those ideas back and actually implement it within their setting under specific problem and use cases. So about 8 projects got launched about a year ago, and all of these projects have actually had good success in achieving the outcomes they had in mind. Those were around the state in California, Minnesota, Missouri, Texas, Tennessee, New York, Rhode Island, and Connecticut. And specifically, this project was designed from the get-go to enable thousands of hospitals, hundreds of thousands of physicians, millions of providers to be able to very rapidly connect to the infrastructure so that they can start sharing clinical data that is so critical to the success of provision of healthcare for the patient. The next 2 pages give you a very quick overview of what problem space that we're trying to deal with on page 30 and 31. Each one had a specific use cases in mind, and again, I won't go through each one of these. You will have access to the presentation material, and there's links in the back of the presentation to the Direct Projects wiki site, which has a lot more detail about what's going on and the results of their collaboration and progress over the last year. But in essence, Redwood MedNet in California started a process to start sharing structured lab results back to the physician and provider, be able to do immunization reporting, and be able to do sharing of patient care summaries. And they've been able to successfully achieve that in California over the last year. Connecticut, the Medical Professional Services Organization, did that with the assistance from the MedPlus, which is the division of Quest, and they were able to demonstrate sharing of summary care information between providers and the local hospital, in this case Middlesex Hospital, as well as the federally qualified health centers. In Minneapolis, they actually focused on public health reporting, and the Hennepin County Medical Center actually started to receive some of the immunization and other reportable lab results back through the infrastructure that was established between the eligible providers in the region or clinics, as well as the public health agency. In Missouri, Cerner is transforming the healthcare by eliminating errors, and specifically the Direct project that they sponsored allowed the replacement of some of the critical infrastructure needed to automate the sharing of patient information. MedAllies in New York, again demonstrating the capability to do that, and in Rhode Island, the Rhode Island Quality Institute is well advanced in their implementation of the Direct infrastructure and integrating it with their long-term HIE strategy. So that's a quick review of what's going on. As I mentioned, you will have links in the back that gives you more details about their accomplishments and progress to date. Tennessee, again, another regional HIO CareSpark achieved the same, and in Texas we have, in essence, a regional HIO in South Texas that is enabling the sharing of patient health information focused on the patients with diabetes and specifically connecting pediatricians, OBGYN, and hospitals in the state, in the South region. So what's going on with adoption? On page 33, what you'll notice is actually pretty wide adoption, which is important. So if you've already invested or already have some EMR or EHR technologies, and you're wondering whether Direct Project can help you, there seems to be pretty ubiquitous or unanimous support for the project, and many vendors that are of significant presence across the country have committed themselves to start to implement the standards and protocols needed to have the Project Direct specifications supported within their technology base. What that means is that if you were to look at Project Direct as an option, you will have fairly good support and a commitment from many vendors out there, both in the EHR community as well as HIE and HISP vendors, who are able to, in essence, help you connect and achieve your goals with respect to meeting stage 1 meaningful use and subsequent evolution to stage 2 and stage 3 requirements. So what are the benefits that you can expect by implementing the concepts we have talked about so far? I guess we'll talk about that in the next 2 or 3 slides. And number 1 is really creating a baseline for exchange that the state can build services upon. One of the challenges that I've heard many of our clients talk about is, I've already invested maybe a year or 2 years in planning and have invested maybe in certain technologies to enable some of this exchange, maybe within specific regions or communities. How do I take advantage of direct project? And what we're finding is that given the approach that the Project Direct has taken, it should be very, very possible, whether you're starting just now or you have an existing investment, is to look for ways to make Direct Project a complementary solution to your existing infrastructure to enable easier standards-based push communications. If you don't have anything, this can become actually the baseline to allow you to build the additional services that you need for a full HIE capabilities. And we'll talk about what that is in a few minutes. But in essence, we believe, and what we've observed is that this can become the core foundation that you can build upon to achieve full HIE capabilities. This can also help the regional extension centers. Again, RECs around the country are focused on helping, in essence, all physicians, eligible providers, and hospital adopt certified EHR technologies and meet the meaningful use criteria. So again, this technology is going to help the RECs in that endeavor and allows them to basically promote the concept of adopting some of these key standards such as CCR and CCD-based patient summaries and be able to help their clientele and the eligible providers achieve their objectives with respect to adoption and putting into use the EHR technologies. On page 36, we continue our discussion about the benefits. This also provides an opportunity for both the states and the RECs to be able to work with a very diverse set of stakeholders, which means that they can actually expand the base of doctors, hospitals, labs, pharmacies that they can talk to and actually provide a very viable and easy to implement approach to start talking about exchanging information electronically in order to improve quality of healthcare and quality of data that's being used for clinical decision making. So again, another opportunity that would be very helpful for the state. And finally, the most important is really addressing and enabling the small practices that are in various stages of EHR implementation. Again, one of the key challenges is if you have a large and diverse geography, how do we provide at least some exchange capabilities without a heavy and significant investment? And what if there is no regional HIE available in a particular region? We believe that the Direct Project can be a very viable platform that helps enable the state-designated entities and the regional HIEs to very quickly get into the basic infrastructure that is needed to help support even the most remote providers who need to participate. What's in it for the providers? We think there's significant benefits here as well. Direct Project can offer easy and affordable, secure clinical messaging to all colleagues and patients. It would be very attractive, hopefully, to a great majority of providers who are looking for inexpensive and easy ways to participate in this process. And of course, if they're applying for the CMS incentives, they need to have a way to do this. It also, of course, helps them meet meaningful use criteria. It is vendor and operating system neutral, and it's really compatible with a very broad range of health IT technologies. So they're not really tying themselves to any particular vendor or technology because of the approach that has been used in implementing the Project Direct specification. It also allows them to not necessarily be a member of an HIO or a regional HIE to benefit from this. It is very viable for a practitioner to choose to have a point-to-point interaction with another physician if both have the ability to in essence, provide secure communication back and forth. But ideally, you really want a state-sanctioned HISP or HIE that is able to issue those digital certificates so that everyone can rest assured that there's a vetting process that ensures that all providers are in fact meeting the criteria to participate in this infrastructure. So what can we do from a state or regional planner's point of view to enable direct in our communities? Specifically, the direct project is a part of a broader national agenda. So as you can see here, you may have heard about the nationwide health information network, and there are several terminologies that you may hear about, and they may all seem to be interchangeable, but they do refer to different concepts and efforts within the ONC initiatives. So one of those concepts is the NwHIN exchange specification. This is the actual specification for exchange of information that is clinical and private, and it has to do with how this is done, what the vocabulary may be, what the transport may be, and it has to do with both push communications and pull communications, and being able to, in essence, match patients that show up in a hospital system versus a clinic or an individual practitioner system. The NwHIN Connect is actually an actual product. It is an open source implementation that is available for use to many clients around the country. It is a federally sponsored initiative where some technology was developed that is being used today for information exchange amongst about 8 or 10 different key stakeholders. And finally, the NwHIN exchange is actually a limited production exchange of a group of large providers and federal stakeholders who are now using that infrastructure to successfully share clinical data. Direct Project is a complementary component to all of these initiatives. And the goal of the project is really to coexist gracefully and successfully with the HIE efforts that are going on both within the states as well as the national level. So Direct Project is simply another initiative that complements the menu of activities going on around enabling this concept of sharing clinical information around the country. Page 40, we talk about the actual services and standards. As I mentioned, the broader set of standards beyond Project Direct talk about authoritative directories that deal with healthcare providers, health plan directories, directories of licensed and clinical labs. It deals with assurances of identity and authentication of services, including the ability to guarantee that the sender is who they say they are and the recipient actually received the message and they are who they say they are, and all the content to be secure as it's routed to other participants. Again, the interoperability goals go beyond just simply pushing data out to any other entity, but to actually be able to match patients and be able to populate automated systems with relevant data so we can actually minimize the manual efforts necessary to, again, manually collect the data by hand and eventually enter into our unique systems within our settings. And also, of course, the NwHIN Exchange has a specification for the capabilities needed, such as a master patient index, a patient locator service, and document lookup and retrieval. So this is the pull capability. So if you show up unconscious to my emergency room, I should be able to, if I have any identifying information about you, query the nationwide health information network and be able to get as much clinical data as I can about you and everything about your allergies and drug usage and clinical background that is relevant to my treatment today. The other models that are, again, around the country as it relates to NwHIN, again, the Direct Project can be used to implement the use cases that are required for push capability, but they can also complement the pull models that may exist. So if you have an existing investment, you could actually use the Direct Project as another easy-to-use standard way of pushing information or clinical information in a secure fashion to the participants. The HIOs may be using a proprietary communication mechanism. Again, that's not a problem. Basically, what we will do here is look at Direct Project as a complementary email-based capability to share data. And also, there is support for XDR integration which allows the direct project push scenarios to support the national standards that have already been implemented by a number of organizations. So how can the state enable direct? What are some of the concepts that may be useful? Again, these are the key ideas that may be useful to consider. Encouraging market-based solution by establishing parameters for trust. What does it mean to have a HISP? How do we authorize a HISP? How do we create a conducive environment for market-driven solutions to evolve? How do we leverage the state HIE services that may already exist within the state? All of those are ideas that need to be discussed and addressed within the context of your specific planning situation. You could also offer a complete set of services to the members. You can buy, build, or contract for HISP. Again, depending on your current infrastructure and capabilities, you could actually build this from scratch without too much effort compared to a full HIE. But then also you can have third-party health insurance service providers provide that service for you, or you could actually engage multiple HISPs to operate within the state as long as the rules are defined. Also, you could look at this as a fill-in-the-gap strategy to make sure that the underserved areas within the state can have a solution. As a matter of fact, many states this year are looking at ways of using Project Direct to deal with rural areas and underserved territories within the state, and that seems to be a very common strategy being utilized. Page 43 speaks to the HIE implementation models. This is an ONC model that you may have seen before, and that talks about how each state plans to develop and deploy HIE infrastructure, everything from the elevator model to the capacity builder, orchestrator, and public utility. And as you can see here, the direct project can be used as a primary to begin with and then expanded, or it can be used as fill-in-the-gap strategy depending on the existing investments within the state. Some of the hidden challenges, these are the things that we've run into that may be useful for you to think about as well. Who will actually be responsible for verification of the qualification of the applicant provider? How will you make sure that the provider who is actually participating is appropriately licensed by the state, or their facilities are current with their licenses and business actually exists and is a current and valid entity to be participating in the process? So that's one of the challenges. Where will the help desk support come from as you deploy this infrastructure? How will you govern the certificate issuance or revocations? Who's in the process? Who will make those decisions? How will you provide access to the nationwide health information network? What about the reporting capabilities to meet the needs of CMS and CDC through this infrastructure? Can this infrastructure be expanded to support a variety of standards that are out there now, and possibly participants who are using non-standard-based technologies? Can that be supported in some way? Can you actually find a logical and practical growth path to take what you have in the Project Direct implementation or HISP and be able to expand that to become a more robust HIE over time? Do you have a data center infrastructure to make sure that you meet the uptime and performance requirements for that infrastructure? And then how do you actually look to achieve Stage 2 and Stage 3 meaningful use requirements? So these are some of the things that may be food for thought as you're thinking about leveraging Project Direct this year. Stage 2 and Stage 3, as you know, is in the formative stages. It's really all about expansion of some of the objectives that have been set forth. So you go from 30% coverage to 50% or 80%. So there's also a number of other suggested or proposed objectives that may show up as a part of Stage 2 and Stage 3. And they're looking at specifically future information exchange capabilities that may expand the standardization way further down to the data elements. And gets into some very innovative concepts around synchronous secure transport, being able to take subsets of the current standards and specifications to expand them to a broader audience, being able to have a metadata for a universal exchange language, which is a very interesting concept, and also being able to support distributed queries to support risk adjustment, quality reporting, and public health. These are some of the concepts that you will see converge over the next year or two as it relates to stage 2 and 3. You could expect stage 2 to be implemented in 2013 and stage 3 around 2015. To bring our conversation to a conclusion, how do you actually take this and turn it into a full-fledged HIE investment? We believe it's very viable for you to start with a direct project and the basic services that are needed for push infrastructure during 2011, and over time add the capabilities to enable the pull capability, specifically the concept of a master patient index, a record locator service, a master provider directory, consent management capability, and public health reporting. So it is very viable based on what we've seen in the market and in the industry and the available technology solutions to combine both vendor-specific and open-source technologies to be able to achieve the goals of starting small with very standardized set of communication capabilities and build more sophisticated capabilities over time on that platform. What we have on page 49 is a quick view of the type of services that you may want to consider over time. The goal is to, in essence, prioritize some of these and start to add these capabilities to the core Project Direct infrastructure over time as you see fit. Some of the critical success factors that we've observed: planning and executing collaboratively with all the key stakeholders, making sure that we plan properly, making a tailored project for the state or the region within the context of your HIE strategic or operational plan, thinking long-term but acting to capitalize on the short-term win opportunities, leveraging the incentive programs to help drive adoption and uptake, defining some very specific measurable goals and milestones, and focusing on the meaningful use from the outset. In conclusion, we believe that Project Direct is a viable and a timely solution that can help to meet your needs around meeting CMS meaningful use requirements and can be the foundation for a long-term strategic solution for the state or the region. We believe there is substantial stakeholder and vendor support for the Project Direct specifications, and there are already a number of very successful use cases around the application of the direct standards around the country. And finally, we believe that the vendor-hosted model of the exchange infrastructure can give you a very rapid and low-cost entry for the region to be able to achieve your goals during 2011. So with that, I'm going to stop my side of the presentation and turn it over to Stephanie to see if there are any questions for us to discuss.
Yes, I do have some questions. If we don't get to all of your questions, still please enter them, and then we'll provide answers via email back to you after the session, along with a link to where you can download the slides, and if you want to share the recorded version of today's webinar with your colleagues, you'll have that information as well. The first question is, are providers required to have direct messaging in order to meet MU Core Measure 14, capability to exchange key clinical information? If no, what other exchange methods are acceptable to meet this measure?
Yeah. Great question. Again, the question is the timing for the implementation. One of the objectives for the Office of National Coordinator as they were establishing the meaningful use objectives, and the reason it turned into a multi-stage planning scenario, is that they wanted to ensure broadest adoption and uptake, as much of an uptake as possible. So with that in mind, the primary goal that they set for 2011 is the enablement of the patient summary exchange, and they also want to see the capability to receive the structured lab results, as well as the ability to enable e-prescription. That's their focus from an ONC point of view. In order for you to attest to that capability, the ideal scenario is that there is at least one option available within the state to do that. There is no mandate that comes from ONC that says you have to implement Project Direct specification within the state. However, they encourage that in a big way because they realize the difference and challenges in doing a full-blown HIE for this state in 2011 versus a direct project. So in 2011, you're supposed to be able to attest to your ability to have a certified EHR that is able to share data with an unaffiliated organization for a period of 90 days. So what you're doing in 2011 is simply attesting, self-attesting that you've been able to accomplish that in order to qualify for the incentives. But that infrastructure has to be a viable infrastructure that meets the privacy and security goals of the state and the federal government, and specifically is able to share the data. However, if you have not done that fully, that is understood, and that is a requirement for 2012.
Okay, thank you. The next question is, for Medicaid hospitals, some of our clinics have satellite clinics as well. Do these file as one clinic or separately? They are both under UAMS, but have separate Medicaid numbers. It would be easier if we could count patient volume for both clinics together.
Right. That's a great question, but I'm not sure about the ONC rules around how they would like you to report your meaningful use objectives and formulas in terms of the numerator and denominator. I have an opinion on it, but let me not go ahead and share that because I'm not sure of the answer. I would say that at this point, let us get back to you with some research, if you could.
Okay. The next question is, do we count visiting physicians in the formula? We have physicians who visit once a week for a year. If they file with us, they can't file under their own clinics. If we don't count them, do we still count the patient encounters in the denominator?
Again, I would say that my opinion on that question would be yes, you can count them in the denominator, but we'll go ahead and verify and get back to you.
Okay. Another question, and from the same gentleman. Each physician registers, but the calculation is the total number of Medicaid patient encounters within 3-month period, numerator. Mm-hmm. Total number of patients seen within 3-month period, denominator. Is this calculation per clinic or per physician? Another one.
Sure.
We'll get back to you.
Yes, it depends on how you have applied for the CMS incentives. Again, when you are looking at implementation of EHR, EMR solutions, if you are an individual practitioner who has invested versus a clinic with multiple practitioners versus the hospital, the rules are a bit different. So I would say it depends on how you have applied for the incentive programs, and of course, a eligible provider cannot apply both as an individual practitioner and as a part of the clinic. So at the end, there should be only numbers in there that are a part of a single application with the Medicare or the Medicaid office.
Okay, and we'll take one last question, and then the rest we'll email. If we are filing in 2011, will our 3-month period be for earlier this year or for 2010?
Actually, it will be for 2011, and so it's the 90 days. In typical scenario, it would be the second half of 2011.
Okay, great. Okay, well, that is it for today, everyone. Thank you so much for attending. Like I said, we will follow up with an email and give you links to the slides and to the recorded session so you can share. If you have any other questions that you think of, feel free to email us, and we will respond back to you with answers. Thank you again, and we look forward to talking to you in the future. Have a great day.
Thank you very much.